It's a pleasure to be with you. The title of this session is Global Health, Education, Economics, and Development Basic Concepts, Part 2. There are no disclosures for this presentation. Objectives include discuss the link of health to workplace productivity, review the impact of health expenditures on family economics, discuss health service access and equity, review suggestions to appropriately use health funding, discuss selecting appropriate data metrics, and discuss the interaction of population health and economic development. Let's now briefly consider the role of worker health and productivity. As might be expected, the health of workers impacts their productivity. Healthy workers are more productive than unhealthy workers. BASTA reported a study of rubber plantation workers in Indonesia. Many of the workers were anemic due to hookworm infection of the bowel. When appropriately treated for hookworm infection and anemia, worker productivity increased by 20%. That increase in workplace productivity, if applied broadly, can improve not only the profitability of businesses, but also result in increases in worker earnings and improvements in the economic status of communities and countries. This graph comes from an article in the Journal of Occupational and Environmental Medicine from 2005 by Burton. He looked at productivity loss for employees having a variety of risk factors: smoking, obesity, inadequate exercise, inadequate diet, stress, etc. The baseline productivity loss is 14.7% for those employees that have 0 to 2 risk factors. Productivity loss increases dramatically above the baseline with increasing numbers of health risk factors. With 3 to 4 risk factors, the increase is 6.2% over the baseline, or a 42% increase in productivity loss compared to those with 0 to 2 risk factors. With 5 or more risk factors, the increase over baseline is 12.2%, or an 83% increase in productivity loss compared to those with 0 to 2 risk factors. So the number of risk factors employees have is associated with the productivity of the business. Workplaces that decrease employee risk factors will see an impact on their bottom line. Identifying and reducing risk factors, primary prevention, is the main mission of public health. This may indicate an opportunity for public health in worksite wellness programs. Less than half of countries surveyed by the World Health Organization, WHO, for worker health plans had endorsed or drafted a national plan of action on workers' health by 2017. WHO's worker health objectives include: 1. Devise workers' health policy. 2. Protect and promote health at the workplace. 3. Improve performance of and access to occupational health services. 4. Provide evidence for action. 5. Incorporate workers' health into other policies. Worksite wellness programs worldwide, if done appropriately, can improve the health, productivity, and earnings of workers and their families, the profitability of businesses, and improve the economic status of communities and countries. Public health is well positioned to facilitate worksite wellness. To effectively do that, public health workers must be appropriately trained in worksite wellness facilitation skills worldwide. Worksite wellness concepts are presented in more detail in other sessions of the North Dakota Public Health Training Network. Let's briefly discuss how out-of-pocket health expenditures can have major impacts on individual and family economics and may lead to poverty. The cost of illness to individuals and their families can be high, can force them to lose or dispose of assets, and can cause them to fall into poverty. Individuals and families frequently have to pay for treatment and for drugs, the costs of which can be a very substantial share of their income. Illness not only increases the out-of-pocket costs of many individuals, but also, at the same time, decreases earning potential due to impacts on work time. Illness or complications of health conditions can be chronic and or lead to disabilities, which can permanently impact earning potential and future healthcare costs. The World Bank's Global Disability Report states that 1 billion people, or 15% of the world's population, experience some form of disability, and disability prevalence is higher for developing countries. 1/5 of the estimated global total of disabled people, or between 110 million and 190 million people, experience significant disabilities. This slide reviews a study from India that demonstrates the impact of illness on family economics. Hospitalization was a major contributor to individuals and families falling into poverty. This survey covered a period of 1 year. 25% of hospitalized patients were pushed below the Indian poverty threshold due to hospital costs, lost wages, and other illness-related expenditures. 40% of hospitalized patients borrowed money to pay for their health care. A 2001 World Bank report summarized it this way: ill health is an important contributor to poverty and to the economic vulnerability that also is at the foundation of poverty problems. Many countries that do not have adequate health insurance are at risk that catastrophic costs of health care will drive them into poverty or bankruptcy. The availability of health insurance is one important way to address ill health once it occurs, a mid and downstream approach. Another important approach to addressing ill health is to decrease the risk factors that cause ill health, an upstream approach. There are 3 major sets of tools to change risky behaviors, upstream issues. The risk factors or underlying causes of ill health, policy, influencing an individual one-on-one, the clinical, and population-based interventions. Policy is developed by local, state, and federal governments, businesses, and organizations. It is an effective tool to encourage healthy behaviors, but must be implemented and enforced to be effective. Clinicians are trained in one-on-one counseling, another powerful strategy to change risky behaviors. Population-based interventions provide another potent behavioral impact and can be divided into 2 tool subsets: social marketing and community engagement. Population-based expertise lies in the discipline of public health. We need all of these tools in an integrated and coordinated way to change risky behaviors in populations. Public health is well positioned to facilitate integration and coordination. In situations where health insurance coverage is limited or non-existent, upstream tools and interventions to change risky behaviors are critical. More detailed discussions of community engagement, social marketing, and integration are covered in other sessions of the North Dakota Public Health Training Network. Let's now consider how health service access raises equity issues. Poor people, ethnic minorities, people who live in rural areas, and women often have less access to health services than others. These groups tend to lack political connections, social power, or influence, and as a result are accorded less access to health services versus groups more politically and socially connected with decision makers. This chart shows the percent of children fully vaccinated according to their family's income quartile, with 1 representing the poorest families and 5 the richest. The higher the income quartile of a child's family, the greater the likelihood that the child will be fully immunized. There are significant differences between the global regions represented in this study, with the Middle East and North Africa having the highest childhood immunization rates in all quartile groupings. This chart shows how different income quartiles benefit from public health expenditures. Public health subsidies for healthcare are disproportionately distributed to serve families with higher incomes versus the poor. As illustrated by these 2 examples, global health service inequities are common and must be addressed to improve the health and wellness of all individuals and families worldwide. There is no justification on clinical, economic, or equity grounds for the current situation. Let's now consider health expenditures and health outcomes. Health is considered important for most countries since they spend a lot of money on health. The higher income countries tend to spend more per person on health than lower income countries. High income countries spend approximately 9 to 12% of their national income on health compared to low income countries at 3 to 6%. The United States spends more than any other country on health as a share of gross domestic product, GDP. Healthcare in the United States is expensive compared with the rest of the world. In 2006, 16% of GDP or gross domestic product in the United States was spent on healthcare. In comparison, Switzerland, France, and Germany spent 10 to 11% of GDP on healthcare. This graph shows the trend of GDP spending on healthcare since 1970. The United States is pulling away from the pack. In 2007, in the United States, every person on average spent $7,146 on healthcare. The general assumption is that countries that spend more on health will be healthier. So is that true? Do countries that spend higher shares of their national income on health have better health outcomes? Let's consider the United States. Despite all the money spent on health, the United States ranks 37th in the world in health ranking, based on a number of components of the Health Performance Index, including responsiveness, meaning respect for persons and client orientation, fairness of financial contribution, or the fraction of what households spend on healthcare, overall level of health, a measure of disability adjusted life expectancy or daily, distribution of health in the population, a measure of inequality, and distribution of financing, or how fairly the financial burden is shared. So it's not just how much money per capita is spent on health, but also how it's spent. So what can countries, agencies, organizations, etc. do to appropriately allocate their health dollars? This slide lists several key recommendations to help appropriately utilize health funding. Organize a coalition of key health decision makers and stakeholders to develop and implement a strategic health plan. Develop appropriate and timely health data collection and analysis systems to provide formative process and outcome evaluations to inform a strategic health plan. Selecting appropriate data metrics is essential. Develop a strategic health plan that should include appropriately balancing primary, secondary, and tertiary prevention allocations to meet public needs. Primary prevention is the main mission of public health, preventing risk factors associated with ill health conditions and their complications. Primary prevention is generally associated with longer-term outcomes versus secondary and tertiary prevention primarily provided through clinical curative, rehabilitative, and palliative care. Integrate and coordinate policymakers, clinical care providers, and public health professionals to accomplish common goals. Public health is well positioned to facilitate integration and coordination of health stakeholders. Assure equitable and comprehensive health service access for the whole population. Equitable health service should be interpreted broadly to include the many social determinants that influence health. Utilize a performance improvement cycle to develop and adjust health strategies. A common performance improvement cycle consists of 4 steps: formulate, implement, review and assess, and adjust. Develop and provide an adequate budget based on strategic health plan activities. The last recommendation on the list, to assure key leader support of the strategic plan and budget. Without leadership support, nothing will happen, even with the best of plans. Inherent within the recommendation to develop appropriate and timely health data collection and analysis systems is selecting appropriate data metrics. Let's spend a few minutes discussing the importance of selecting appropriate data metrics. All governments have limited money to spend on health programs. Therefore, they must prioritize health expenditures. One important tool for setting priorities is cost-effectiveness analysis, which is a method of comparing the cost of a health program investment and the amount of health that can be delivered for that investment. The disability adjusted life year, or DALY, is a common metric used to inform budget priorities. The disability adjusted life year, or DALY, was first used in 1993 in the World Development Report of the World Bank. A DALY is a health gap measure. DALY is a measure of overall disease burden expressed as the cumulative number of years lost due to ill health, disability, or early death. The formula for DALY equals YLD, or years lived with disability, plus YLL, or years of life lost. The DALY relies on an acceptance that the most appropriate measure of the effects of chronic illness is time, both time lost due to premature death and time spent disabled by disease. The sum of these DALYs across the population, or the burden of disease, can be thought of as a measurement of the gap between current health status and an ideal health situation where the entire population lives to an advanced age, free of disease and disability. This slide lists some key factors that influence dailies and health expenditure decisions, including the incidence and prevalence of a health condition or burden of disease and the extent to which the investment serves society as a whole, the cost of an intervention, the extent to which an intervention can reduce morbidity, mortality, and disability, the impact on the provision of insurance, and how effectively and efficiently an intervention can be implemented. If there are several alternative interventions, it's important to determine which intervention will be the most cost-effective. For example, this slide summarizes an evaluation of two alternative Partners in Health program approaches to delivering HIV prevention and care in Haiti using either paid or volunteer workers. Although it cost more to deliver the program when workers were paid, the outcomes were superior to those when the workers were not paid. The results of this study of service delivery alternatives helped Partners in Health to decide to continue to pay workers versus using volunteers, since the benefit outweighed the cost. This chart shows the cost per daily averted for select health interventions in a South Asia region of the world. For low-income countries in this region, one coronary artery bypass surgery costs approximately $5,000. This surgical intervention would benefit one individual who may live an additional 20 years of good health. A complete course of tuberculosis treatment in this region costs about $100. We assume that tuberculosis patients who receive this treatment will live an additional 20 years in good health. With these similar outcomes, $5,000 would either treat one patient with coronary bypass, adding 20 additional healthy years, or 50 patients with tuberculosis, adding 1,000 additional healthy years. As demonstrated in the chart, providing basic childhood vaccinations, TB treatment, emergency obstetric services, oral rehydration services for diarrhea, and treatment of depression would be more cost-effective than providing dollars for coronary bypass surgery. This type of information is included in cost per daily averted analysis for various health interventions and demonstrates the value of this data in developing health expenditure priorities. Let's consider a few brief comments about assure equitable and comprehensive health service access for the whole population. Equitable health service should be interpreted broadly to include the many social determinants that influence health. This slide lists several factors or determinants that significantly impact the health and equity of people worldwide, including the physical environment, health behaviors, primary prevention practices, individual characteristics, and the social environment. All these determinants need to be considered and appropriately dealt with to assure equitable and comprehensive health service access for the whole population. Even though some of these metrics and considerations may be very helpful, it's important to state that there are no standard cost-effective thresholds. Each country must consider all the factors associated with their unique needs and budgets and make wise decisions. Let's now consider health and development for a few minutes. There is no doubt that good health promotes economic development. Poor health requires health dollar expenditures that preclude funding allocations for schools, roads, small business loans, and other economic development infrastructure programs. Countries with high burdens of infectious or communicable diseases are not commonly considered good investment opportunities for foreign investors. For example, countries with a high prevalence of malaria are associated with a reduction of economic growth of 1% per year. This table lists a few studies that show the relationship of health to development. The World Health Organization report in 2001 demonstrated that countries with a life expectancy at birth, LEB, of 77 years are expected to grow economically 1.6% faster per year versus countries with an LEB of 49 years. An African study by Bloom et al. In 1998 showed that there was a slower rate of economic growth in countries with poor health versus countries with better health. Fogel, in a historical review, stated that improvement in nutritional status and health status boosted productivity and economic growth in Europe. So the health of people does have an impact on country development. The converse is also true, that country development has an impact on health of individuals and society in general. Pritchett et al. In an article titled "Wealthier is Healthier" demonstrated that countries with higher income levels were associated with better health and a longer life expectancy. So there is a bidirectional impact between development and population health as diagrammed. In 2004, a panel of economic experts titled the Copenhagen Consensus was convened to identify cost-effective investments to improve global welfare. This table lists the order they recommended. The very good recommendations included control of HIV/AIDS, provide micronutrients, liberalize trade, and control malaria. The good recommendations included develop new agricultural techniques, develop small-scale water technologies that could translate into small business opportunities, develop community-managed water supply and sanitation programs, increase research capacity for water and food productivity, and lower the costs of starting new businesses. Notice that all of the climate control measures were considered bad investments for global welfare. These were economic experts, not public health experts, and provides insight into the perspective of economic professionals. Public health would likely prioritize investments differently. Working with groups who have different perspectives but common goals is the focus of boundary-spanning leadership. Boundary-spanning leadership concepts are covered in other sessions of the North Dakota Public Health Training Network. In summary, worksite wellness programs can improve the health, productivity, and earnings of workers and their families. Global health service inequities are common and must be addressed. Health outcomes are not just related to how much money per capita is spent on health, but also how it's spent. Selecting appropriate health metrics is essential. There is a bidirectional impact between development and population health.